Good afternoon, everyone. Welcome all to today's Indians program. Today we have Psychiatric Rehabilitation Services Indian Scenario. The lecture is going to be taken by Dr. Jagadisha Thirthalli, who is Professor of Psychiatry and also Head of Psychiatric Rehabilitation Services at NIMHANS. He's a well-known researcher in schizophrenia, ECT, and psychiatric rehabilitation in India and worldwide. So we welcome you for today's class. One more thing about today's class is that this session is usually not found in textbooks. The Indian scenario. We'll read about rehabilitation elsewhere. We can read it in textbooks. But what happens in India, most of us would not know during our MD DNB days, or even after when we start practicing. When I had given DNB theory exams, this was also one of the questions which we had to face. At that point of time, it was very difficult to answer because we did not know much about this. But now we have brought this up topic so that everybody gets helped by this topic, not only in writing answer if a theory question comes, but also to refer people, to help people. It would be relevant to know what happens in our own country. With this introductory remarks, I hand over the stage to Dr. Jagadisha Thirthalli.
So good afternoon to all of you. In today's lecture, there are, you can say that I will be dealing with two important divisions of this lecture. One, I will be talking nearly about 1/3 of my lecture would be about some concepts about rehabilitation in psychiatry. We all, when we talk about rehabilitation, we all have different perceptions about what is rehabilitation. I had checked with one of my teenage nephews about, have you heard of rehabilitation? He immediately said, yes, I know. It is something that is done to people who get addicted to mobile phones and computers and video games. For them to come out of it, that is called rehabilitation. So that is his version of rehabilitation. Many people talk about rehabilitation as a de-addiction process. Rehab is very much linked to, forcibly taking a person who is addicted to alcohol or any other kind of substances into a group of people in a place where they are restrained, they are denied of these substances, and they are treated in a different way, kept for about a few months, and then released as if they have been rehabilitated. This is another very stereotyped perception about what is rehabilitation. When it comes to core psychiatric rehabilitation, many people get this picture of daycare centers or places where people who are hopelessly symptomatic and for chronically symptomatic, nobody can take care of them for in their homes, and they are kept in some place indefinitely. So that is considered as rehab. Some daycare centers where people make some candles, covers, or so they stitch some things or do some crafts, that is equated with rehabilitation, or keeping patients forever in a secluded place as rehabilitation. And many of my former students ask me, can I set up a rehabilitation center? When I ask what it means, they would say that it will be something like a halfway home or a long-term care, etc. I do think that these are all important parts of rehabilitation, but I want to focus a little bit on a nuanced perception of what is rehabilitation. I'll be talking about this nuanced perception in a while from now. The second half of my 2/3 of my lecture would be mostly about factual details about the Indian scene. As Chetan was saying, if you get a short notes on rehabilitation Indian scene, the latter part may be of some help to you. But the first part will hopefully make you better clinicians and to look at person as a holistic entity and help the person to achieve what he or she wanted to achieve before they became sick. In this lecture, you will see many references in brackets. You keep those things in mind. The reference list will be given at the end of the entire presentation. I hope this PowerPoint is being shared with them. You can go through them. Many of these references are our own publication. Not because I wanted to sell myself, but I just wanted to highlight that we have dirtied our hands into this and learned over time. And you can find very good cross references from these references. Okay. Now, there are two terms: psychiatric rehabilitation, psychosocial rehabilitation. What are these? Now, in my opinion, psychiatric rehabilitation is part of a psychosocial rehabilitation. Psychosocial rehabilitation is a much broader term, not necessarily constrained to psychiatric conditions. For example, in the current COVID situation, psychosocial rehabilitation of migrant workers, psychosocial rehabilitation of displaced population, psychosocial rehabilitation of persons who are undergoing trauma. So they are not necessarily linked to psychiatric conditions. So, but yet, like for example, there is a dam constructed, a lot of tribals get displaced from there. So they also can be given psychosocial rehabilitation. So we are not going to talk about that. We are going to talk about psychiatrically ill people, especially those who have severe mental illness, developmental disabilities, how we can help them to improve their quality of life and how they can lead satisfactory life. That is what is called as psychiatric rehabilitation. Today's lecture is going to be about psychiatric rehabilitation. Rehabilitation, the definition is restoration of something that is lost or damaged. In health, it is restoration of health and complete functionality. Is rehabilitation different from treatment? Now, if you ask me that question, I will ask a cross question. What is the goal of treatment? Is the goal of the treatment is to cure the disease, irrespective of what happens to the person, then it's a different story. I think the goal of treatment is not only you treat the illness, but also you help the person who has the illness. For example, if a person comes to me with hallucinations and I give him clozapine, which controls hallucinations very well, but he sleeps for about 16 hours a day, would that be a successful treatment? It will be something similar to a person having a successful cardiac surgery and the person dies out of septicemic shock. So the operation is success, but the patient is dead. So treatment in psychiatry should not end up like that. Treatment is not about symptoms. Treatment is about the person. So there is a large overlap between treatment and rehabilitation. The goal of treatment ultimately is rehabilitation. So roughly we can say that what we do with medicines, etc., can be considered as treatment, psychotherapy, etc., etc. But once the symptoms are under control, to enhance the person's life situation, we can call it as rehabilitation. So when it comes to the goal of treatment in severe mental illnesses, importantly, we need to get the freedom of symptoms. Without that, we cannot talk about rehabilitation. Another important aspect is prevention of relapse, and the person should remain as much as possible in remission and optimal functioning in all spheres of life. Most clinicians do a good job of the first two because it largely depends on pharmacotherapy. The third one requires more resources, and it is hard to find such resources, so it may get ignored. I have one suggestion for all clinicians. At every consultation, the psychiatrist should ask himself, can this person do any better than the current condition? Over time, we get used to seeing that, okay, person came with delusions and hallucinations or manic symptoms or depression. Now these symptoms are not there, he is doing well. Is that so? Can he do anything better? If you ask this question honestly, every time that you see a patient, you will find that rehabilitation is very, very important. Because pharmacotherapy alone cannot be a satisfactory answer. So here on the one end of this road, we have remission, where the person's symptoms are better. If you ask the person what does he really want, in addition to remission, he wants recovery. He wants to pursue his life goals. That is what is recovery all about. But from remission to recovery, there are so many hurdles that you can see in this. It could be negative symptoms, post-psychotic depression, demoralization, stigma, discrimination, expressed emotion, side effects, financial difficulties, many things that pharmacotherapy cannot help. In this road, which is topsy and turvy, rehabilitation finds a place. Now, who needs rehabilitation? Nearly almost every person with severe mental illnesses and developmental disabilities will require rehabilitation. The question is how much we may be able to provide and with what quality. If you are asked a question about evidence-based rehabilitation procedures or interventions, you have this here. There is a long list of evidence-based interventions which are useful for psychosocial rehabilitation, social skills training, cognitive retraining, family intervention, CBT, etc. But there are a number of challenges in providing these high-end rehabilitation interventions to many people. Like, for example, how many people need it? Nearly almost everybody needs it. Do we have human resource? We don't have human resource even to give them pharmacotherapy. We have, okay, one person may require multiple interventions. Okay, a patient who has recovered from, let's say, schizophrenia may have residual social anxiety as well as cognitive difficulties. So, who can give both of these interventions to him? It can be challenging. You take the life course perspective. Rehab needs of a person who is student is to finish his education. He finishes education. Now the challenge of who will give him an occupation comes. Somehow you get him an occupation. Now he looks at marriage. Marriage comes with its own baggage of challenges. Post-marriage, childbirth, child rearing, parenting. Every stage of a person with severe mental illness, you find some challenge which a clinician should take into account and help the persons with. Biggest challenge in our country is accessibility. Where do we get rehabilitation inputs? Where is the time? Where is the place for that? Can they afford it? You may have a wonderful concept of, let's say, art therapy or drama therapy. Can a village dwelling person accept it as a useful treatment? Acceptance is an issue. Longevity of the effect. You may do a very good job and restore the person's cognition, let's say. Suppose there is a relapse. Does the intervention that you did, does its effect last post a relapse also? We don't have answers for these things. There are so many challenges in delivering these evidence-based psychosocial interventions as part of rehabilitation. I'll tell a little on early intervention and continued management. I think it is very well known that early interventions help in psychiatry in general. There is a very good review. You can see this in the reference number 2. But if you carefully look at it, the focus is as much on early, but it is also on continued engagement. There is no point in treating early and not sustaining it with a comprehensive package of rehabilitation. Because if you just intervene and leave, the person is very likely to relapse, and each relapse adds to disability. It is very well known that a person who has another relapse will experience some kind of neurotoxicity. I also talk about what is called a psychotoxicity. With every relapse, the person's confidence will come down. The person's chances of getting more cognitive impairment, more despondency, more demoralization increases. Of course, there will be what I call it as sociotoxicity. with every relapse, the person's he goes away from the society. Families get frustrated, community gets frustrated, employers get frustrated. The person effectively goes away from his main track with every relapse. So prevention of relapse and prevent is equate, you can equate with prevention of disability, which is a very critical part of rehabilitation. That is where we should focus on relapse prevention for a comprehensive rehabilitation. So ensuring adherence is critical, and mind you, non-adherence is a very complex issue. It's not just about, okay, he is non-adherent, we will give him flufenazine. He's non-adherent, we will give him surreptitious medication. It is not as straightforward as that. There is a lot of things that is required. Continued availability of continued availability of medicines at the accessible location. There is cost issue, there is adverse effect issue, perceived improvements, insight, stigma. There are so many things that determine adherence or non-adherence. So it is important that clinicians should be aware of it. So how many of the patients that we see will require advanced interventions that I listed a few slides ago? I think my colleagues have talked about this pyramid. And at the bottom, you can see what people will require in large numbers. That is self-care and informal community care, which are very, very cost effective. They require less amount of resources. A lot of people need it, but we can supply that with less inputs. When you go to the top of the pyramid, it is in the top of the pyramid, you will see high-end rehabilitation inputs, which will be required by a small number of people, but the costs are very, very high. This is what we give in places like NIMHANS, which will be useful for only a small proportion of people, whereas a large proportion of people just require a little bit of help, and it can be given very easily. Like patients and families may be self-reliant in majority of the cases. So for them, continued pharmacotherapy alone is the rehabilitation input. But it is very crucial. For their rehabilitation, ensuring continuous medications so that they don't relapse is very important. For the middle level, for DMHP, social workers can do a lot of these things. Trained lay counselors may be required to provide a smaller proportion of people, and only a few will require highly specialized inputs. So a large proportion of patients just need minimal professional intervention. That is because in India, families do what in Western countries may be called as case workers work. They ensure adherence to medication, they engage with treating teams, they help about comprehensive rehabilitation, they provide a warm atmosphere in most cases, not in all. And patients can take help from community and governmental and non-governmental agencies and rehabilitate themselves. Okay, but it is very crucial that all these family and community involvement is there. The professionals are not required in here. Does it work? Yes, there is plenty of evidence that just continuing medications and just doing very brief psychosocial intervention, mostly to ensure adherence and see to that the person is engaged in some work or not, will help. It improves the course and outcome of the illness. It improves work-related outcome. It reduces disability and social participation. It reduces family burden, and it reduces the cost of treatment. All of these are Indian research, which has shown that for rehabilitating people in community, all that you need to do is to ensure continuity of care and do very low intensity psychosocial intervention, helping the people to get back to their routine. It is possible. Hence, an important part of Indian contribution, important part of psychiatric rehabilitation in India is to do with the NMHP and DMHP. Right now, the emphasis in NMHP and DMHP is on identification and initiation of treatment. But we should move from there to ensuring continuity of care and rehabilitation, this becomes very important. I anticipate that the DMHP should slowly move into CBR programs, community-based rehabilitation programs. There is enough evidence that CBR works, but it is in CBR projects. My colleague Dr. Sivakumar would have spoken to you about CBR project versus CBR program. CBR projects are small time, limited focused interventions, whereas CBR programs are sustainable and they are for a larger population. CBR projects have been done. There is enough evidence that CBR works. What we need is CBR programs, which should take the rehabilitation to the communities. Interestingly, under the National Mental Health Program in India, there is provision for taluk level social workers for mental health. And many of the references that I gave in the previous slide, we have used one taluk level social worker to deliver a lot of rehabilitative inputs. And with that amount of input, it was possible for providing comprehensive and sustainable CBR. We have just started a very ambitious program of Karnataka State Holistic Empowerment Program for Mental Ailments called Kshema, which is precisely trying to get these taluk level social workers to deliver comprehensive CBR. Having said that, I will come to the stereotyped perception about rehabilitation. The age-old perception about rehabilitation, that means this daycare, long-term, etc., etc. So I don't want to belittle them. They are very, very important. I completely agree that it is very important. And the following are very important as part of it, which are long stay homes, short stay homes like quarterway, halfway and 3/4 homes. Quarterway homes are from mental hospital to halfway home. So they are intermediary between mental hospital and halfway home. 3/4 homes are from halfway home to communities. And then community living, there are other options of community living. And then daycares and independent living options. These are all traditionally associated with the stereotyped perception about rehabilitation. Who are providing these rehabilitation inputs in India? Or the institution-based rehabilitation, who is providing? The government is not very big in its role in institution-based rehabilitation. There are a few tertiary care institutes like NIMHANS where a comprehensive rehabilitation input is available. In Karnataka, there is a program called Manasadhara, where the government, with the help of NGOs, runs daycare in all district headquarters in a private-public partnership model. There are a couple of long stay facilities, or you can call it as halfway home-like facilities called Manasa Kendra in Karnataka. I'm not very sure, there may be such programs in other states as well. But there are, to the best of my knowledge, there are no government-run or government-supported long-term facilities where people who cannot be cared for anywhere else will have to be cared for. But many patients are stuck in mental health institutes. Now, many state governments have long-term care facilities for children and adults with intellectual disabilities. I think in almost all districts, there are places where adults and children with intellectual disabilities are housed and looked after by the state. Under the National Trust Act, the NGOs can apply for these following, that is Vikas, that is daycare, Samarth, that is respite care, Garaunda, that is group home for adults. These are not for mental illness. These are for developmental disabilities, including intellectual disability, autism, and cerebral palsy and multiple disabilities. Recently, in 2018, a revised version of Deen Dayal Disabled Rehabilitation Scheme has been launched. Under this scheme, for mental health, NGOs can apply for halfway homes. The government will fund halfway homes, but the government will not run these halfway homes. They will fund the NGOs to run halfway homes, and there are also funds for starting special schools for children with intellectual disabilities. These are some of the government supported or government run rehabilitation facilities that one can look at. But a major part of this institution based rehabilitation is done by private sector. So there are not for profit organizations or NGOs. They play a very good, very big role in rehabilitation. There are some profit facilities, for profit facilities, like private halfway homes or private places where they take a lot of lump sum of amount and take care of the person with disability for many years. There are a few medical colleges which are also private medical colleges which are running daycare. There are some medical colleges which run long-term care facilities as well. Some of the examples of these NGOs that you can note: Richmond Fellowship Society, that has branches in Bangalore, Lucknow, Delhi, etc. Then there is Schizophrenia Research Foundation, SCARF, which runs daycare and long-term care facilities and community facilities also. Then there is Schizophrenia Awareness Association in Pune, Medico-Pastoral Association in Bangalore. There are many of them. Now, where can you find all these things? There are two resources you can note down, which are from NIMHANS. On the left side, you find a directory of mental health care centers. Many of these are rehab centers, which are available in South India. The reference number 16, you can download this PDF. We have recently launched a website called RAH. It is under construction, but you can explore this as of now. It is not complete. So you can get some information, but not complete. So this is another source that you can look for. Now, talking about rehabilitation homes for persons with mental illness, large proportion of homeless persons with mental illness, they are called as HPMI. Now, large population of these are mental illness. If you look at homeless people, many of them will have mental illness. How many of them are there? I don't think we have good numbers. I mean, the numbers are elusive. It runs into a few lakhs, I guess. Why do we have homeless persons with mental illness? It's a very complex situation. Many patients with mental illness may wander off and they don't know how to go back to their original places. But a substantial number of them have family issues. Either the families have deliberately rejected them or deliberately left them in some forest or some railway station and gone back, or they would have burnt out over time, taking care of this person, repeatedly relapsing person. Okay, Baba, bus, I think it is over now. I need to get rid of you. That kind of burnout can be there. Then very commonly you will find many of these homeless people having comorbidity with intellectual disabilities, substance use, epilepsy, etc. Of course, there is poor community care. I mean, the care of these people have been done only by families. There is no support from the society, no support from government, and it leads to some kind of burnout and abandonment. Right now, where are these people living? These people are in mental health institutes, either government run or private NGOs. Many of them are living in so-called beggars colonies or destitute homes. Each state government runs facilities for people who are otherwise homeless. Many of these facilities seem to house people with mental illness. There are many religious institutions like temples, dargahs, churches, and their subsidiaries which take care of people who are homeless with mental illness. Each state government runs homes for women who don't have other places to go, or vulnerable women. Many of these houses are full of persons with mental illness also, in addition to not mentally ill people. There are many old age homes run by private or NGO people. A large number of them will have persons with mental illness also in them. Of course, prisons and streets are the other places where you will find homeless persons with mental illness. What is the problem with the institutes? There is poor standard of care and quality of life overall. There is loss of autonomy and freedom. All kind of freedom that we enjoy, people who are in institutes are deprived of. There is no personal freedom. I cannot go out. I cannot choose my friends. I cannot have recreation of my liking. I cannot have relations. I don't have cousins, uncles, aunts with whom all of us enjoy. Don't have as much religious freedom as I would have outside the institute. I have to depend completely on others for financial freedom. Of course, I cannot vote in many cases. I cannot, have a ration card. I cannot have a Aadhaar card. I don't have the identity of myself. This is what happens to people who are stuck in mental health institutes. Of course, there is over time they lose their own identity. They become part of the institute. Despondency comes in, demoralization comes in, poor quality of food and living arrangements. People are in uniforms, which again takes away the sense of identity. They get stereotyped. They lose over time they lose social occupation and other kind of social skills, and it becomes increasingly difficult to discharge them. But the good thing is that there are a lot of efforts being made to take care of these homeless persons with mental illness in India. NGOs are taking an active role to provide better life for them. I have listed a few. There are many of them. Shraddha Foundation of Mumbai, or somewhere near Mumbai, which has reunited about 8,000 plus people of homeless persons with mental illness to their families. The Banyan in Chennai, which has now branched out into Trichy, Kerala, Maharashtra also. They also take acute and long-term care of homeless persons with mental illness. They have a unique program called Home Again, where group houses are provided for women who are recovering from mental illness with a lot of freedom. They get all these freedoms that I listed in my previous slide. Chittadama in Karnataka, Ashadeep in Assam. These are some of the examples of how NGOs are taking care of homeless persons with mental illness. What about those who are stuck in government institutes? There are about 43 government-run mental institutes in India. In the recent survey that we did, 6,000 patients are there in these 43 government-run institutes who are staying for more than 1 year. And majority of them are in a dischargeable condition. They can go back to the community, but they are stuck there because of various reasons that I enlisted as causes of homelessness. The numbers were higher earlier, and the conditions were extremely pathetic about 2 decades back, I would say. But now these places are relatively better because the NHRC, National Human Rights Commission, has sent its team repeatedly to these places, recommended, made sure funds come, and the quality has slightly better. I mean, substantially better, but still much lower than what one would expect. There has been greater budget allocation to these institutes. There have been very, very good proactive mental health medical superintendents of these institutes who have improved their institutes very well. Of course, there are some of these mental health institutes have started running PG courses, and when they run PG courses, they get a little more manpower. They become more open, and they seem to improve their quality overall. Judiciary has a long, very, very powerful presence in the long-term care of persons who are stuck in government institutes. There has been a couple of public interest litigations about patients who can be discharged, who continue to languish in mental health institutes. Now, the central and state governments have recently come up with a roadmap for discharging these people and providing them aftercare so that they will not go back to the same institutes. Then there are active efforts to trace their families and transfer them to the many less restrictive facilities. But we should be mindful that there is a risk of what is called as trans-institutionalization. They are now institutionalized in government settings. If families don't come forward, but there is pressure for us to discharge them from government institutes, we may end up discharging them to other institutes, which may not be very dissimilar to uh, the government health institutions, or even worse. So that we should be watchful and guard against such a eventuality. So patients should not be shifted just because we need to empty the government health institutions. I'm not going to talk too much about legislations about rehabilitation in India. These have been covered. But I want to just highlight that in these legislations, rehabilitation has been given a very strong impetus, particularly in the first one, Rights of Persons with Disabilities Act. Access to comprehensive rehabilitation is now the right of the persons with disabilities. If a person is denied of rehabilitation input, the responsible government will have to be, can be pulled up by judiciary, by the law. It provides for many entitlements like pension, like reservations, like reservation in education, job, and then health insurance, etc., which helps a lot in recovery process. Reservation in jobs and educational institutions, we have the central government and many state governments have already identified which jobs can be reserved for persons with mental illness who apply for these posts under the disability quota. Mental Health Care Act again says treatment is the right of the person, and treatment includes accessible and affordable home-based and community-based rehabilitation. So again, Mental Health Care Act says that rehabilitation has become the right of the person with mental health related disabilities. National Trust Act is there, which is focusing on developmental disabilities. You should be aware of this Rehabilitation Council of India Act because it sets the standards for rehabilitation professionals. People who work with disabled persons and for rehabilitation must be registered either with the Rehabilitation Council of India or with the Medical Council of India under the Mental Health Care Act. So without these registrations, rehabilitation professionals can be considered as doing some kind of a quackery. So that should be avoided. This this act is very important from that perspective. You may be aware or may not be aware that there is a National Institute of Mental Health Rehabilitation, very fresh. It was initiated just last year in Sihor district of Madhya Pradesh. It is under the Ministry of Social Justice and Empowerment. It focuses on clinical care, human resource development, and research in mental health rehabilitation. And it is already running a course for caregivers of persons with mental health related disability. There are other national institutes which are related to mental health care disability rehabilitation. That is National Institute for the Empowerment of Persons with Intellectual Disabilities. It is in Secunderabad. It was formerly known as NIMH. And there is National Institute for the Empowerment of Persons with Multiple Disabilities in Chennai. We have professional bodies in India which work for mental health rehabilitation. World Association of Psychosocial Rehabilitation has an Indian chapter. It is a member of WAPR Global. Indian Association for Social Psychiatry also focuses a lot on rehabilitation. Again, it is a member association of World Association of Social Psychiatry. Indian Psychiatric Society, IPS itself, has a specialty section on rehabilitation. All these professional bodies hold conferences related to, directly or indirectly, to mental health rehabilitation. Indians are very big in rehabilitation in the world field. The current president of WAPR is a former professor of NIMHANS who is working now in MS Ramaiah Medical College, Dr. Murali. Vice President is from India, and Dr. Matthew Varghese, who is the treasurer, is from NIMHANS. Coming to the last bit, Indian research on rehabilitation psychiatry. Indian researchers have been very active in research in psychiatric rehabilitation. It is difficult to quantify the contribution, but because they have published in different keywords like rehabilitation, disability limitation, recovery, retraining, etc. These may be the recover. These are some of the words that they would have used. So if you want to search how many papers are there on rehabilitation about mental illness in India, it is difficult to get. But if you put in a keyword of rehabilitation in IJP alone, you get about 350 plus papers. So Indian research in psychiatric rehabilitation has appeared in several reputed journals also, not just Indian Journal of Psychiatry. Very top-end journals also have published like Lancet has published many papers related to rehabilitation of mentally ill people in India. Of course, we have our own journal of psychosocial rehabilitation and mental health. So a couple of us in NIMHANS are the editors in chief. So this is this is not an Indian journal, it is an international journal, but its editors are Indians and we publish a lot of research from India in this. So these are the references for what I quoted in my talk.
Thank you very much, sir. Thank you for your lucid presentation, as usual. So there is one question though from Manjunath Masali: how to get guardianship for mentally ill patients?
Yeah, I think the rules have not yet come for the guardianship. It is to be in Karnataka state rules. I think it might have come very recently during this pandemic. There was some news on that. I'm not very sure. Just a few. Before this act came, it was always through the court. Now I think similar to National Trust Act, there are local level committees which may be enabled to issue guardianship. Otherwise, it is. The route through the court is very clear. You can always appeal to the court to get a guardianship. But there are other avenues also. I think under the RPWD Act, it is being made a little more easy so that guardianship can be given from what are called as local level committees, which are easy to convene and easy to get the guardianship. But mind you, the guardianship is going to be only limited guardianship. In the earlier act, there was something called as plenary guardianship. Once you get the guardianship, forever the person was a guardian. Now it will be for a limited period and for a limited purpose only, unless the person is, let's say, very profoundly retarded or has profound IDD. In such cases, you can go through the National Trust Act that is still in vogue. You can get easily from the local level committees. I hope it answers the question.
How can PSW help apart from counseling? What is their role?
PSW has a very large role in rehabilitation. I would say counseling will be the least important. A lot of persons with one thing that PSW can definitely do is to explore the challenges for continuity of care. Okay, there are very what I can call as modifiable factors for non-adherence. It could be distance, accessibility of medicines, availability of consultants for follow-up, etc. PSW can easily coordinate this and see to that the person does not stop medication and relapse frequently. So that's a very big contribution a PSW can do. But the PSW can also do a lot more things. He can be an advocate for the person's rights. He can help him to get disability certificate and enjoy all the entitlements and other facilities that the government can give to the person. These may look very small, but they go a long way in helping the person. I'll give a small example. Disability pension. How does it help in rehabilitation? If not for anything, the money can be used to get medications which may not be available with the government, or that, let's say somebody has a lot of sedation with clozapine, or let's say risperidone or olanzapine, which is available free from the government. But the person may do very well with aripiprazole. Aripiprazole will not be available. in a government setting. The pension money can be used for that. So the PSW can coordinate this. The PSW can work with what are called as village level rehabilitation workers, multi-purpose rehabilitation workers, district disabled welfare officer, and help the persons to get a lot of benefits of disability certificate and its uh, 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 follow-up of the certificate. And of course, they can help them in educational rehabilitation, vocational rehabilitation, network with NGOs which can accommodate rehabilitative inputs for these patients. So PSWs have a very, very big role. In fact, psychiatrists have very less role.
Is there any public-private partnership or any financial help offered by government for private mental health professionals willing to establish mental health rehab facility?
If you have an NGO, yes. There is a very clear, there are two schemes I can straight away say. There may be more. I'm not an expert in this. One is Deen Dayal Upadhyaya, Deen Dayal Rehabilitation Scheme. It is a central government scheme which has come just last year, 2018-19 it came. An NGO can apply for running a halfway home through this. The government will fund it gives a substantial fund. I think you may have to get some other funds from some other source and run it. Manasadhara is another PPP model which is running in Karnataka. You can apply for running a Manasadhara in any of the districts of Karnataka.
Sir, apart from referrals, what can an individual private practitioner do to rehabilitate patients?
As I showed in one of my slides, please ask yourself whether this person can do better. Many of us get satisfied with the symptom relief. That should not be done. We should always look at whether this person's life can be improved. There are a lot of things that a psychiatrist can do, provided he should give time. Time is crucial. So you cannot rehabilitation. You cannot do rehabilitation only by medicines. Medicines are important. You see if the person is disabled, can you do any changes with medications so that his ability to work will improve? Like if he is drowsy, review the medications and give him less sedation causing drugs. See if there is significant social anxiety can be there in many people, which may show as negative symptoms. The person may not be meeting with people, but there may be social anxiety. Many a times they may have some obsessions which may prevent them from going for work, etc. So that kind of clinical inquiry into what can be modified in this person, that I think goes without saying. Now beyond that, the person can do brief family interventions, liaise with NGOs for any employment or education opportunities, or work with any religious based people who can also help the person getting some not just religious, any other kind of people who do a lot of activities which are social in nature. So encourage the person to get into this. Sometimes this social skills etc will improve by doing some of these things. So of course each individual will have a different challenge and each individual psychiatrist has to deal with them. But if you spend more time, you can find many methods of rehabilitation.
Sir, has RPWD Act suggested development of newer setups like halfway homes or sheltered workshops in India?
Yes. Yes, it has.
Sir, what are the family interventions in psychiatric setting in rehabilitation?
Yeah, I mean, it completely is a question about family intervention, not so much about rehabilitation per se. There are many methods of family intervention. The psychodynamic therapies, analytic family therapies. There are behavioral family therapies. There are supportive family therapies. These are varieties of family therapy. Now, coming to rehabilitation, you can use any of these. Apparently, psychodynamic and psychoanalytical family therapies are contraindicated in schizophrenia, but I have seen people doing that as well. But behavioral methods of family therapy, any family therapy geared to reduce expressed emotions, go helps in rehabilitation.
Sir, how to start a rehab center and what are all the permissions required?
Chetan, I think you should answer this.
So again, not to advertise, we have bought up a book called Nuts and Bolts of Starting and Running Psychiatric Rehabilitation Services from NIMHANS publication. It is available through NIMHANS publication also, or you can place your orders to our mail also. We send that book. It costs 200 rupees as of now. So in that book, we have also spoken not only about the nitty-gritties of how to start and run rehab services, but various permissions required, various acts to which it should be compliant. This was bought before Mental Health Care Act and RPWD Act, so only that legal chapter is a bit old chapter. But otherwise, it also has chapters on what should a PSW do, what should a clinical psychologist do, what is the role of psychiatrists, nurses. So it has various chapters on all these aspects. So one can go through that book to know more about how to start and run rehab services. Thank you, sir. Sir, how to build a sense of community?
Build a sense of community among people with mental illness. It happens more or less automatically if any person who has been running a daycare center will, or any other long-term psychiatric rehabilitation centers will vouch for this, that it is very commonly observed that many of them gel together and develop a sense of community by themselves. Or I don't know whether that is the right, that is what is expected of this question.
Of different skills you mentioned, which one do you think is the most important? ADL training, social skills training, which of them is most important?
I will ask the patient, which is most important for you. That is most important for me.
So what about the multidisciplinary?
Welcome to person-centered approach. So we don't decide anything. Okay, patient and the family as a unit, they will decide what is important for them, and it works wonders if you adopt this and not impose what you think is important.
Sir, at this juncture, I also want to bring in one of the statements usually given by Dr. Sivkumar, who is additional professor of psychiatry in psychiatric rehab services. The moment you realize that you are not like a doctor, you are not paternalistic, you are like a server in a hotel, then your learning for psychiatric rehabilitation begins. So like the way a server in a hotel will not impose what is good in their restaurant to the people who come there, they simply ask what do you want, and the people usually ask what they want, and you provide that service. If you think that is not good, you only suggest. You don't go back to the even though the person has ordered something, you don't go back to the kitchen and rework up the order, you give something else to the person. That doesn't work. So only when you satisfy the needs of the person who has come, actual rehabilitation starts.
Yeah, so it's true of not just rehabilitation, Chetan. It is the duty of every doctor, let alone psychiatrist, to do that.
Yes. Sir, what about multidisciplinary approach to intensive care in these rehabilitation in India, and how much are we integrating them back to community?
I think it depends. I think in NIMHANS, our experience has been fairly good. I think we used to be very overcrowded earlier. Now, I think many of our patients have been reintegrated into families. There are many places where it has happened. Dr. Ravi Shankar was with us. They have integrated dozens of patients from Chitradama who are homeless to their families. Shraddha Foundation has done it in thousands. They have reintegrated with their families. So Okay, reintegration is not a single step. It's a process. Okay, so it doesn't happen as an event. You might have reintegrated the person back to family, but how sustained is that reintegration is important. So it is not just about discharging the person, it is about maintaining him or her in the community in a good health becomes an important aspect. So in that sense, backup support is very important. That is where local resources of psychiatrists, DMHP social worker, psychologist, etc. come into play. And that is, if that backup is there, reintegration can be done more successfully. It is multidisciplinary, of course.
Sir, continuing this, like if the family is not willing to take care of the person despite being manageable, is there any legal recourse for this?
To the best of my knowledge, we cannot force the family to look after a person unless he is elderly. I think for elderly, I mean, if the patient is elderly and the caregiver is a son or a daughter also, I don't know, but there is a law in India, Chetan, you may know, which will mandate that the sons should take care of their parents. But I don't think there is any other law. I mean, of course, if the child, the patient is minor also, it is the obligation of the parents. For normal adults who don't fall into these extremes, there is no law which can force a sibling or a wife or a husband that you must look after this person. Now, if the family is not taking care of the person's responsibility lies with the state. The state is obliged to give care for these people. But fortunately, I don't think the numbers are in enormous amount. There are a few thousands or maybe tens of thousands of people who are left without any support, where state either has been taking care or NGOs are taking care. But we need to move a lot in this direction, and the state should start giving quality and quality care, including autonomy and a true sense of rehabilitation and recovery for these people, and not just close them down into one mental health institute.
Sir, in addition to that, what also has been told in RPWD and Mental Health Care Act is also that something called as least restrictive environment. So this least restrictive environment can be in the community, can be in a halfway home, can be in the hospital also. So it doesn't tell that, okay, least restrictive environment is only in the family and only there the person has to be rehabilitated or rehabilitated too. It is not so. If, as I was mentioning, there is no law to mandate people to go back to their families, but the state means to say either right now the district disabled welfare office or the district commissioner will be, or the person who is heading the Department of Social Welfare and Justice. So these are the people who will usually come into picture to take care of persons with mental illness, because they'll be the guardians as nominated by the government if they don't have any other guardians. Sir, how to give specific psychiatric rehab effectively in sustainable basis, especially during disaster situations?
If you know the answer, please tell us. We are to tell the least, rehabilitation itself was in disaster before the disaster came to us. Okay, so we never had a very satisfactory picture of rehabilitation in India for majority of the patients. A small number of patients were able to get very good quality rehabilitation in some institutes, NGOs, etc., etc. Now that, I mean, if you are talking about a disaster like Corona pandemic, then we are trying to do our best through tele counseling. We are having telephonic and video-based interventions with individuals and their families, and based on the individual's background, etc., we are able to get them to engage in some activity or the other. I would say it's too early days for us. Over time, I think I'm very hopeful that we will learn from this and emerge with innovative ideas as to how to engage these people. I think one resource I will tell you, the NIMHANS recently released a book on mental health care at the time of corona pandemic. In that, there are a couple of chapters on rehabilitation. You please go through that. You may get a few ideas from there.
The book is available in NIMHANS website free of cost to everybody. Sir, please comment about the future of mental health services in Indian scenario.
Fingers crossed. Yeah, I'm very hopeful that the what shall I say, aspirational legislations like Mental Health Care Act and Rehabilitation, Rights of Persons with Disability Act will kind of, if not revolutionize, improve the situation of mental illness and rehabilitation process in India. I hope a few of you will take the activistic role and advocate for your patients' rights. If all of us become activistic and put these laws into practice, it will improve. If we as professionals do not spend time and advocate for our patients and clients, it may not happen. Of course, we can always advocate for families to come together and demand for their rights. If there is demand, I think the laws will mandate the government to give good service. Incidentally, I just observed that there was a lot of demand for alcohol, and government started giving alcohol during the pandemic. We didn't see any such demand made by persons with mental illness. I need treatment now also, please give me that. So this kind of activism, if it is there, it will be good. Sir, thank you for your valuable time coming here and taking this class. It was a wonderful class. Kindly subscribe to our YouTube channel, NIMHANS Indians. You will find all our videos there. This is the 33rd class we are having in Indians. So you will find all the other videos there, and any new upcoming videos also would be posted there. So kindly watch our YouTube channel, subscribe to our YouTube channel. We thank Dr. Jagadisha sir for taking this class. We also thank Clinics Laboratories Chennai for giving us academic grants to run this program. Thank you, everyone.